The challenges we face is that we don't know this patient. We don't know if they had care or not. And if they do, sometimes we don't know how far along they are. We have to quickly make a determination as to whether how far along they are. And that will help us make a decision as to what we need to do for them. The ones that do come in that are difficult, they either come in either in labor or have been ruptured for a while, or they are in pain and they want some pain relief. They are brought in here to us and we respond and take care of them. And for those patients, often we do get their records because their midwife do send their record with them or fax it to us, and we're able to determine how far along they are and we take over their care. And if they are really full term, that is more than 37 weeks of gestation, we allow them to labor, and most of them successfully deliver vaginally. The other type of patient we see are those patients that have already delivered outside the hospital and they are brought in for postpartum hemorrhage because they are bleeding. Either placenta may still be retained or they have a deep laceration that they cannot repair outside the hospital. Those patients are brought to us and then we do the best we can quickly to assess them and then repair the lacerations where indicated. I think the relationship between us as an institution and the birthing centers around the area has dramatically improved since starting our OB Hospitalist program in 2012. We have dedicated physicians who do this job and they're here 24 hours around the clock and 7 days a week. And as a result, we do have quarterly meetings with these midwives who work at the birthing center on the quarterly meetings. And this has been going on for a long time, but we do have it more often now. And the reason is to debrief and also to look at some of the things we can do to help them out to improve the communications and transfer patients to us and when to transfer patients to us. And that's the fact that we meet face to face and discuss this has made it much easier for them to get used to us as the physicians and nurses who care for these patients. We allow them to have choices within guidelines of the American College of OBGYN. We don't strap them down on the bed and just let them labor. We have portable monitor that we can attach to them so they can ambulate and walk around as long as they want. And when we do see any problem, we bring them back to the room and reassess the babies at that time. So we are not quick at rushing to deliver them by cesarean section. Even if they may rupture for 48 hours, we bring them in so long as the baby is comfortable and stable and no sign of infection. We continue them on antibiotics, and many of them do proceed to have a vaginal delivery very successfully. Only a very few of them end up with a C-section for one reason or the other. You do have a choice, and we want you to have that choice. If you are a low-risk pregnant patient, it's fine to go to a birthing center if that's what you chooses to. We're always going to be here for you should you run into any complications. But if you have a high risk, by that you have any other medical issues along with your pregnancy, I would prefer that you have a physician take care of you, because you have somebody who consistently is going to take care of you not only during your prenatal time, during the time of delivery, and after you've delivered. So you already have a relationship with a physician who now knows your record and we take care of you. That is all I ask for those patients who are of high risk. What do we call high risk? People with diabetes, hypertension, or somebody with a blood disease or thyroid problems, somebody who's had a previous cesarean section. Those people are not allowed by American College. It's discouraged. Don't deliver outside the hospital.